Our next speaker is Monica Minjeur. Dr. Minjeur is a family medicine physician at Unity Point in Bowman Woods in Cedar Rapids, Iowa, who has completed training and is a Creighton model and NAPRO technology medical consultant. At this seminar, she will describe the mechanisms of action of chemical contraceptives, list health benefits and common side effects of contraceptives, compare and contrast different methods of natural family planning, and describe fertility awareness techniques used for conception and fertility. Please welcome Dr. Monica Minjeur.
Good morning, everyone. We're going to try this technology thing here. I wish I could speak like Vicki, just kind of go, 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 but I need something to keep me on track. Otherwise, we'll all be here for 3 hours today with just my talk. So I'm going to give just a brief overview and introduction to fertility awareness, as well as some different natural family planning methods. A little bit about my background first, though. I was born and raised in New Hampton, Iowa. It's a small community up in northeast Iowa. Grew up on a farm. I'm the oldest of 5 kids. I did my undergraduate work at St. Louis University, majoring actually in theological studies. I knew I wanted to go into medicine, but they told me, you can do whatever else you want for your undergrad. So I said, ooh, theology sounds kind of cool. So some of this background for me started in my undergrad work, so that's an important piece for me here. I did my medical school training in Kansas City at the University of Medicine and Biosciences. I am a doctor of osteopathy, which some of you may know the difference, MD versus a DO. Basically, we do all the same stuff, except doctor of osteopathy has a little bit more focus on musculoskeletal medicine, holistic medicine. And then I did my family medicine residency in Mount Clemens, Michigan, which is a suburb of Detroit. And that's actually where I met my husband. And then while I was in residency, I found out about this method of fertility awareness, Creighton model, and becoming a NAPRO technology medical consultant. So I actually did that training. It's about a 7-month training in total. There's a week that we do in Omaha, and then it's followed up by 5 to 6 months of self-study, and then another week that we go back in Omaha. So I completed all of that training while I was still in residency, so that when I started practice, I kind of had all this stuff under my belt. So first question I'd like to kind of address is, how does modern medicine generally correct menstrual irregularities and symptoms that occur around the time of a woman's period? And the answer is some type of hormonal regulation. So I see this all the time. Young women come to me and they say, oh, I have acne and it's really bad around the time of my period, so my doctor put me on birth control and now my acne is better. Or, hey, I have really bad menstrual cramps, really bad migraines around the time of my period, so my doctor just put me on the pill and said, good luck, see you later. And hopefully throughout the presentations today, you'll kind of understand not only the reasons why is that bad medicine, but also it's not fixing whatever underlying problems may be present. So as far as hormonal contraceptives, there are a couple of different things, and I do have in quotes here proposed mechanisms of action. So when you read about any type of medicine or hormone, if you've ever gotten a prescription from a pharmacy, you get that huge pamphlet that says, these are all the things, this is what it does, these are the possible side effects. So these are some of the things that are listed as mechanisms of action. So one of the things for birth control pills is it says it will stop ovulation, that it changes the cervical mucus to block sperm, and that was something Vicki just had alluded to, can alter the movement of the egg itself, and to stop implantation of fertilized eggs by changing the uterine lining. Now, all of us probably know of somebody who has still gotten pregnant while they're on the pill. Okay, we've all heard stories about this. So that's why I say that these are proposed mechanisms of action, because these things still happen. We know even from people who are charting their cycles, who are keeping track of things, that we still can see cervical mucus happening. We still see ovulation occurring even when they're on these types of hormones. So it's definitely not a fail-proof mechanism. The intrauterine device, or an IUD, proposed mechanism of action. There's one particular type that releases hormones to reduce ovulation. That particular IUD stays in your body for 5 years, okay, releasing these hormones continuously over 5 years. And all of the types of the IUDs, they irritate the lining of the uterus to prevent implantation. Now this can cause really serious problems, because if fertilization does still occur, that baby doesn't have a spot to implant. So oftentimes it will implant in a fallopian tube or somewhere else that's not supposed to be, causing ectopic pregnancies. So some very serious issues here. Contraceptives are prescribed for avoidance of pregnancy. Okay, this is the FDA-approved definition for it. However, these two are the only two that are actually FDA-approved indications: avoidance of pregnancy and acne. Okay, I want to go back to acne for a second, though. If you are a young man and you come into my practice and you have acne, I'm not prescribing you the birth control pill, okay? So there are other things that we can use to treat acne, okay? So that's a huge thing that I focus on in my practice. No. We don't put you on birth control just because you have acne. Whether you're a young woman or a young man, it's just not appropriate. PMS, or premenstrual syndrome. Some women come to me and say, oh yeah, I have PMS like everybody else. No. Premenstrual syndrome is a separate thing. There are different things that we can do for it, not just give you a contraceptives. Irregular bleeding, okay? Dysmenorrhea or painful menses. Iron deficiency anemia. I'm having my period too often, it's too heavy, whatever the case may be. So they put me on birth control to stop it. Menorrhagia or heavy menses. Ovarian cysts, okay? I see this oftentimes that people come to me and say, oh, I had this terrible pain, and they did an ultrasound, they said I had ovarian cysts, so they put me on the birth control pill. I go back and I look at the ultrasound and I say, that wasn't an ovarian cyst, that was your ovulation, that was a follicular cyst, you were ovulating, you had a regular egg that was supposed to be happening, that's supposed to be there. And somebody still put them on birth control because they thought that was an irregular thing, okay? So sometimes knowing what the normal is very important. Ectopic pregnancies or tubal pregnancies I had mentioned, and benign breast disease. This is another interesting one, is something called fibroadenomas. Very, very common, especially in young women. They can be very painful, benign breast lumps, and typically they'll pop up around the time of their period. So some doctors have gone to prescribing hormones to try and help regulate and try and reduce that because it's something hormonal, it's related to some female hormone thing, something or other, blah, 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 put them on the pill, okay? Osteoporosis, which is interesting, as Vicki had mentioned, is that particular types of contraceptives can actually cause osteoporosis. So why are we treating people with contraceptives for osteoporosis? It's kind of a tongue-in-cheek there. And as I mentioned briefly before with acne, alternative methods exist for reducing the incidence of all these problems, okay? If you come to me and you have any of these problems, I have a way to treat all of this stuff without doing any type of hormonal contraceptive, okay? Disadvantages of contraceptives, common side effects that we see: irregular bleeding, weight gain. Almost every woman that I see has some form of weight gain. Depo-Provera, in the instructions, it will say especially, average of 15 pounds in 1 year, just because of this hormone. Nausea and vomiting, decreased libido. So those are the common ones. Less common side effects, but things we still see, as Vicki had mentioned, blood clots. I think every doctor out there has had a patient or 2 or 4 or 10 that have had some type of blood clots. This was really, for me, the reason that I started looking into this. I had a young cousin, she was 24, no other risk factors, and she ended up with pulmonary embolism. Thank the Lord, she survived and is doing fine. But at the same time, I go, why else? Why would we go down this road? There's got to be a different way. Breast cancer, especially breast cancer in young women under the age of 45. Cervical cancer, typically what we see in general for people who are not contraceptive, cervical cancer is much more common in younger women. But what we find is for people that are on the birth control, the longer that they're on it, their bodies are less likely to be able to respond to fight off those cancerous cells. As Vicki had mentioned, with autoimmune disease, with the changes of cervical mucus, our bodies don't have those same protective effects. And so cervical cancer in older women, which is typically not common, or at least didn't used to be very common. Liver tumors, gallbladder disease, hypertension or elevated blood pressure, and infertility. Again, we see this kind of across the board. And then again, ectopic pregnancy, specifically with the IUD. This is just an interesting slide. Now this is a little bit dated. This is information from 1996, so things have gone up quite a bit. But comparing the cost of different contraceptives, and you can kind of see up here as far as the cost of each of these particular types of contraceptives, how often those things need to be either replaced or renewed, or how often they're used. And then looking at the cost over a lifetime to prevent some particular type of ailment that may or may not actually be physiologic to the body. So people are, not only taking a part of this, but it's a huge, huge financial cost as well for contraceptives. When we look at contraceptive pregnancy rates, as I mentioned earlier, probably all of us know of somebody that's, oh, I got pregnant and I was on the pill, or I had the IUD, or I had a tubal ligation. So these are kind of some different breakdowns here. A couple of things that I'll point out specifically. Typical use means how it typically works in general practice. So just by chance, 85% of the time. So if you are not doing anything for contracepting, you're not having any type of fertility awareness, about 85% of the time you will get pregnant, okay? Perfect use is a little bit different. Perfect use means if I am using this method 100% of the time. So for example, if we look down to the oral pill, kind of midway down the screen here, typical use means, oh, some days I forgot to take my pill, I just didn't take it at all for a week here, I forgot it here and again. So that's considered typical use, 5%. What they consider perfect use is that 0.1 to 0.5%, okay? And then the other thing that is really interesting with this, 1 year continuance rate. So if you look at people that are using contraceptives, at 1 year, how many of them are actually continuing that same method of contraception? And you'll see that oftentimes it's 50%, sometimes 70, sometimes up to 80%. But what that typically is telling us is that people don't like this, okay? Even people who don't know what's going on, they're on the pill, there's something that happens that they go, you know what, I don't like this, it's not working for me, I'm having side effects, something else is happening to say, this is not a good system. So women intrinsically know that something is not right with this, but you know, for whatever reason, I'm gonna switch, I'm gonna try something different. There was a study recently that came out that showed young women under the age of 20, on average, had tried at least 4 different types of contraception by the age of 20, okay? This is before this whole prefrontal cortex is formed, okay? The problem with that is that not only are we jumping around to different hormones, but there's all of these different things that are saying, I have to shut this off, that this is unnatural for me. There are obviously, and part of the reason we're here today is to help present some advantages of fertility awareness methods and natural family planning. So part of what kind of drew me into this work, especially with my medical background, is that these methods, you're able to adapt them to any cycle length, any circumstance, okay? If you are a woman who is having periods, and even if you're not having periods, we can use these methods to help determine, is there something that's going on? Can we use this to help achieve pregnancy, prevent pregnancy, wherever you're at in your cycle? It's medically safe. We're not doing harm. And that's one of our oaths as a doctor that we take. First, do no harm. So there's no side effects to tracking your own natural fertility. These methods are proven reliable. Depending on studies that you're looking at, some of these studies, some of these methods have been in place for ages and eons. Some of the newer methods have been very, very well studied, even over the last 40 to 50 years. And comparatively inexpensive. So for the most part, these methods, you learn how they work, and you're able to use them then for the rest of your life. The other nice thing is that it is standardized. You know, it's not well, I kind of feel this way today, so that means I'm fertile or I'm not. There's very specific signs that you can see to know, is this a time of fertility? And if it's not, you know, is that normal? Is that not normal? And then the big one, obviously, avoiding the side effects from the synthetic hormones. The other nice thing that sometimes doesn't get talked about is that this does provide a chance for a joint responsibility between spouses. So not only is this just tracking a woman's fertility and her fertility cycles, it really creates this beautiful opportunity to involve both partners in discussion about our fertility, rather than just, oh, when is the woman fertile? Okay, put her on the pill and shut it off and whatever. This is a discussion, this is our fertility together. Disadvantages of fertility awareness methods, there is a learning curve, okay? So you'll see that the information you're presented today, it's not going to be enough for you to just go home and say, cool, I'm doing this now. So there is a little bit of a learning curve. It does take some dedication and commitment. It's one of those, you can't just say, okay, I'm doing this today, and then I'm going to take my pill tomorrow, and then I'm going to do it again the next day. So there is a bit of that. Other than that, that's it for disadvantages. I mean, it's otherwise, once you learn a method, it's easy, it's cheap, it's sometimes free, depending on what you're doing. So how many methods of fertility awareness are out there? These are the ones that are actually, as far as documented, studied, a couple that I'll present. Now there are some newer methods that are coming out, so I don't need to disclude those. A lot of them just have some overlap with some of the older methods. So basic concepts. Men are always fertile, okay? Pretty much from the time that they've kind of hit through puberty, unless there's something else that happens. But sperm are produced and available 24/7, all right? So that's important to know. However, women are not always fertile, kind of as Vicki had mentioned before. This depends upon time of ovulation. Fertilization requires three things: an egg, sperm, and cervical fluid or mucus, okay? Which is why it's really important when we talk about methods that inhibit that cervical mucus, why that makes a difference. So just a brief overview of a couple of different methods here. The calendar rhythm method. This is probably the method that if you have grandparents or great-grandparents or beyond that, that's typically what they use because this was created and kind of standardized back in the 1930s. But it strictly calculates the days of fertility based off of the number of days in your previous cycles. So if you are somebody who has very normal cycles and they occur on a regular basis, you have about the same number of days every cycle, this method actually is not a terrible method, okay? However, it does have some lack of versatility in women who are breastfeeding, who don't have regular cycles. Or if you're somebody who has what we call prolonged anovulation, which means that you're not ovulating on a regular basis. By and large, there are many, many women who don't have a period every 30 days. This method is not fantastic for that, but it does still work. It does lack the precision. This is something, I like to show this picture. This was the old rhythm calendar dial. So I showed this picture to my grandma one time. She said, "Oh, I had one like that." And I'm like, "Oh, that's really nice. And did you actually use it?" And, "No, not really." And I'm like, "Oh, that's why you have 11 kids." And, okay. But for her, this was something that she had. And basically what it does is, again, it just kind of shows the number of days that you had your last period. And then you just kind of turn the little spinner, and it'll tell you, hey, these are the days that you're fertile, and this is when your next menstrual cycle is supposed to begin. So there are lots of apps that are out that do this same exact thing. So overview of a couple of other methods: basal body temperature. So this relies on taking a daily temperature. This is one that's been kind of developed more recently, I think about the 1950s, to help determine the time of ovulation. Body temperature should be taken at approximately the same time every day. Ideally, they say first thing when you wake up in the morning. However, it can be affected by lack of sleep, by alcohol, by illness. All of those things can adjust as far as where your temperature is. One kind of tough thing with using just temperatures is about 5% of cycles have shown to have ovulation that happens earlier than expected based on that. So that can lead to a little bit of inconsistency. The other thing is that it needs an increase in hormone levels in order for that temperature to spike. So if there's something going on with a woman's hormones that don't cause that spike to happen, then that temperature shift never happens, and it's a little more difficult to utilize that. Symptothermal method. So this integrates a few different symptoms. It does use observation of cervical mucus or fluid, breast tenderness, vulvar swelling, ovulatory bleeding, as well as cervical changes. And it kind of pulls all of those things together in order to help a couple determine when a woman is pregnant. It also oftentimes will include the daily basal body temperature. Some concerns with it, depending upon who you are, there can be some variability in symptomatology. So what one woman might consider to be menstrual cramping, another might just say, oh, this is my normal daily baseline. Or what some may consider to be cervical fluid may be just a normal baseline for others. And the daily temperature readings come into play a lot. The other thing that I didn't mention with the temperature readings, it's affected if you're nursing, if you are up overnight with another infant and trying to gauge that, it can be thrown off a bit with that. Marquette method. So this method, designed up at Marquette University, utilizes mucus observations plus a daily urinary ovulation kit. The initial and long-term cost is a bit more on this one because you have to purchase an actual fertility monitor and you purchase strips, and then you use those strips on a daily basis to determine if you're ovulating or not. The system itself works fantastic. It's very accurate. However, that cost long-term if we're looking at using this for 30 or 40 years for some women, can be a little bit higher. However, there are some people who prefer to see, hey, yep, I've got that definite answer that I know a hormonal shift has occurred. It's just kind of that double check. The methods that I'm going to talk a little bit more about now, the Billings and Creighton models, are what we consider a mucus-only method. Now, this is the particular system that I trained in, is the Creighton model. So if it sounds like I'm a little biased, I probably am, just because this is what I trained in and this is what I use. And so what this does is it relies only on external examinations of the mucus. It's able to be objectively identified, and I'll show you a little bit later how we objectively identify that. The reason that I really got drawn to this method, though, is that it's one of the only methods that also has medical identification for irregularities, and it has kind of this co-partner piece that we call NAPRO technology. NAPRO stands for Natural Procreative Technology, and so there's a whole system that utilizes this particular method of tracking in order to be able to kind of say, okay, scientifically, this is what a woman's observing. Scientifically, how do I take that and turn that into something that's usable that I can help to identify these irregularities and help correct them going forward. The other beautiful thing about this method is that it's able to adapt for any and all cycles. So whether you're breastfeeding, whether you're around perimenopausal time, I work with a lot of couples with infertility issues, and ovulatory cycles, as I mentioned, if there's no egg that's being released, and people who have variable length cycles. So lots of women, I also deal with lots of young women who have polycystic ovary syndrome. They may not have a cycle, but every 3 months, 4 months at a time. And so this method can be used with any of those types of cycles. One thing when we look at mucus channeling, so what we're talking about when we talked about when are women fertile, we talk about the cervical mucus. So on the left side here, you'll see this is what mucus looks like under an electron microscope when a woman is infertile. So you can see lots of kind of just dead-end channels. So if sperm are trying to get through, it's not going to let things happen, okay? Whereas on the right side, you see this is what fertile cervical mucus looks like. It's a super highway, all right? So it's going to let things on through. So that's the actual science between what is the difference between fertile and infertile mucus. This is a slide talking about natural family planning methods, pregnancy rates. And now this is important because it's in people who are trying to avoid pregnancy, okay? So what we talk about as far as those different methods that I just kind of overviewed. Now these are studies done by each method in particular, okay? So the people who do Creighton model, this is their study on this, okay? Marquette method, this is their study on how things work. And as I talked about previously, actual use is the day-to-day utilization of this, and then perfect use. So when you look at these numbers, and I know it's kind of hard to remember back to the contraceptive slide, however, when you look at these numbers, overall these numbers are all better, or at least similar, to pregnancy rates for trying to avoid pregnancy in people who are contracepting, okay? When you look at rhythm method, that's one where we're talking about that little calendar and numbers of days. So 15 to 25% can still achieve pregnancy with that. Again, as I mentioned, it's not a perfect system. So things you can do, use Creighton model to either achieve or avoid pregnancy. Evaluate infertility, as I mentioned, that's kind of the NAPRO piece that goes into it. Evaluation of irregular cycles, and evaluate unusual bleeding. So sometimes we get people who come in and they have bleeding in the middle of their cycle, or some other time that shouldn't be there. Identification of ovarian cysts without ultrasound all the time, which is interesting. Treatment of PMS or premenstrual syndrome, as I mentioned, lots of people just think, oh, everybody gets moody right before their period. That doesn't necessarily happen, and so depending on severity, there are things that we can do to help treat that. Treatment of postpartum depression, okay? This is something that oftentimes doesn't get talked about a lot. There is a whole protocol within NAPRO technology for treatment of postpartum depression. It is a very easy protocol that does not involve putting people on long-term antidepressant medications, having other issues that way. What happens is when you deliver a baby, you lose that placenta. That placenta is a huge source of progesterone in your body. Now all of a sudden you go from today I have a placenta that has a lot of progesterone, and tomorrow I have a screaming infant and I have no progesterone to deal with it, okay? So what that does is that it kind of helps us to identify if there's postpartum depression, how can we treat it quickly? We've had some fantastic success stories on treatment that have allowed people to feel like I'm a normal human being again, I can be back on my feet within 24 to 48 hours. I mean, it's just that fast. It's faster even than if we started them on antidepressant medications. So what cycles will it work with? As I mentioned before, kind of everything. So regular cycles, irregular cycles, anovulatory states, breastfeeding, premenopause, people who are post-pill or patch or injections. We do start charting with some people who are still either coming off of some type of contraception. Sometimes people are leery to transition off, so we'll say, hey, let's start you charting while you're on it. We can look at that. So a couple of things charting with Create Model. As I mentioned earlier, just a disclaimer, anything I present here is not going to be enough to go home and go, oh yeah, I know Create Model now, I'm good, I'm going to start charting. So there are lots of resources for people who can actually teach you some of these methods, so we can get you in contact with people who can actually teach. So don't go home and go, cool, I'm an expert in this, more just, oh yeah, I want to learn more. So, picture dictionary teaching. So, what this is that when you learn with an educator or with a practitioner, what we do is that they go through and they kind of go step by step and they say, okay, this is what cervical mucus is, this is what normal is, this is what abnormal is, this is what things should look like. There are very specific pictures that we say, if your mucus looks like this, then it means you are this and such number. So we have this standardized recording system so that it's standard across the board. So if I talk to a patient on the phone, I can say, hey, tell me about your cervical mucus. And my patients know, like, this isn't a weird conversation now to have. And they'll say, oh, today it was 10 KL. I will know exactly what that means. I can talk to another patient that lives on the other side of the state, and she'll tell me, oh, I had 10 KL, and I'll know that it means the exact same thing. That's the nice thing about having it standardized. It's not a matter of saying, oh, it was kind of sort of whitish, stretchy-ish, I don't know. And it's a very specific standardized system, and we use this across all of Create Model charting. Create Model has been taught literally all over the world with this standardized system. And so if you're talking to somebody who is charting and they're in sub-Saharan Africa, and you're talking to somebody charting in Chicago, Illinois, they will be able to give you the exact same descriptions as far as what's going on with this. Overall then, how we translate that into an actual chart is this is what a normal cycle of charting should look like. And basically what you would see is just each each month we chart in one line, okay? So what we would see is that this top line here is just 1 month of charting. So typically what will happen is for those first 5 to 7, sometimes more, sometimes less days, will be the days of actual menstrual bleeding. Generally, then we see a short cycle or short days of dryness where there's no cervical mucus. And then we see some days in the middle, and those days are days that women observe mucus, okay? This is leading up to fertility. I don't know if you guys can see this, but those are little white baby stickers that are on there, okay? We try and make it really simple. A white baby sticker means you are fertile at this time. A baby could happen if you're using those days in order to try and achieve pregnancy. And then typically what will follow is another number of days where things are dry, okay? So when you look at this cycle, what we say is that any of those days that are green days mean that you are not going to get pregnant if you have intercourse on those days, okay? So the idea is that when we look at these charts as a NAPRO consultant, as a medical consultant, we're able to see, okay, ideally we get things to looking a little bit more like it's a normal cycle. That helps us really to determine, are there irregularities, are there things that need to be changed, fixed? And what we can see is there is oftentimes cycle variation. So this is a chart of an actual patient. This is 3 consecutive months of charting. Now, this would still be considered a normal chart. What it tells us, though, is that it doesn't always happen. Things don't always happen at the same number of days, same number of time, and that's okay. That can be very normal. So if you can see on the first line, for example, the numbers that are on the left and the right are the numbers on the left are the number of days before ovulation occurred. The numbers on the right are the number of days that happened after ovulation occurred. Typically, if we see variation, the numbers are going to be variable on the left, the number of days that happen before ovulation occurs. If you can see, the numbers on the right are fairly consistent. Usually we say that's within 1 to 2 days of each other every cycle, and that's why I say that this is still normal. However, if you're looking at a chart, and this happens quite frequently, where women come to me and they say, I'm not fertile, I've been trying to get pregnant for X number of months, and my OB told me that I'm fertile on day 18, and that's when we should aim for having intercourse, okay? So if we look at the first cycle, for example, day 18, kind of right in the middle there, falls on a dry day. Okay, so this person is not going to get pregnant if they just focus on day 18 and afterwards. Same with that second cycle, all right? It's not going to happen. Third cycle, they may have been in luck if they chose that particular cycle in order to use that day 18. But that's why it's so important that people are knowing and tracking their cycles, is that in medical school, there was a blip that talked about this much about natural family planning, and it talked about none of this stuff. Everything that they told us and taught us talked about when you were checking labs and evaluating somebody with infertility, check based on ovulation of day 18, okay? What we realize is that's not what actually happens, okay? Prevalence of infertility, and again, Vicki had kind of mentioned that this has gone up significantly over the years. And what we find is the number of women with impaired fertility, this is a CDC study done by the Department of Family Health, is increasing as we go. And prevalence among married women, anywhere from 10 to 15%. This is just an example of, these are actually 5 different cycles. These are actually 5 different women, but looking at infertile cycles, okay? On the first line, it kind of shows that this is a particular individual who had literally 1 white baby sticker in her whole chart, okay? So had some troubles with infertility there. The second cycle looks pretty normal when we look at it, but this is also somebody who had struggled with infertility for over 5 years. The third one, that one's maybe a little bit more obvious. There was no white baby stickers there. So this person was not having any type of fertile mucus. The fourth line, it showed that things looked like they started off okay, but then if we look at the number of days after she had ovulated, there wasn't enough days. So she may have been getting pregnant, but wasn't able to sustain a pregnancy because those hormones in the after she had ovulated had not been consistent. And on that final line again, it kind of shows something that looks like it should be normal, but wasn't. So sometimes when we see these charts, it's not easy to just tell based on the chart, okay, why are we having troubles with this? And that's kind of where we come in as the medical consultants. So I get asked sometimes, when is the best time to get pregnant? Okay, first of all, I say, okay, you gotta be charting, because you gotta know when you're actually fertile. However, any time mucus is present can be considered fertile, although not all mucus is considered the best time to try, and that's why we talk about the different charting systems as far as knowing what types of mucus, what color, what stretch, all of this stuff is gonna be considered the most fertile. If having problems with getting pregnant, we tell people to aim for the time of their ovulation or their peak day, and then trying for intercourse every other day around the time of ovulation. Some people think more is better. We should try to have intercourse 7 times a day, every day, and that's not necessarily always the case. The other thing that's interesting for people to note, and something that we don't get taught, is that you can still remain fertile up to 3.5 days after you have actually ovulated. So it's not like you get just this little short window of 1 day of ovulation. You actually have 3.5 days afterwards and people can still get pregnant. So on average, how many days each cycle is a woman fertile? And it's different for every woman. The average is anywhere from 5 to 12 days. So that's the other thing I get asked often is people tell me, oh, well, we're supposed to do this natural family planning thing, but I've heard that you just have to abstain all the time if you're not wanting to get pregnant. And that's not actually the case. What we find is that, like I said, on average 5 to 12 days. If it's more than that, there are things we can do to help make that window a little bit more narrow to kind of make things be more appropriately aligned with that. However, again, all days that mucus is present can be considered fertile days. This is a chart put out by Pope Paul VI Institute. They're the ones who are kind of the leaders in all of this work with NAPRO technology. And this is just a chart showing achieving pregnancy, and this is in couples of normal fertility. So what they did is they took 50 couples who were trying to achieve pregnancy, and they looked to see, okay, if we are giving them only this charting system and then teaching them how to use it and they're wanting to get pregnant, how long does it take them to get pregnant? Within the first cycle, within the first month of using just this system alone, 76% of those couples became pregnant, okay? That increased significantly in the next 2 to 3 cycles, and by the time that they had reached the 6th and 7th cycles, 100% of these people were pregnant. Now, the caveat with this is these are in couples with normal fertility, okay? And the other thing is there was no other medication intervention here. So, but by and large, this does happen quite often. I get people that come to me all the time. I've been fertile, they want me to do IVF. I said, let's just try and chart for a couple of cycles. And then they call me up and say, oh, never mind, we're pregnant. We're good now that we've done this. So it makes my job really easy. I look really awesome then. So this is achieving pregnancy in a regular cycle. And so basically what you'll see again is kind of that first line is the charting. And then on the bottom here, you'll see below it, we have couples mark an I when there's been an active intercourse. So they utilized those times of fertility where there were actually baby stickers there, and they were able to achieve a positive pregnancy test. My other fun thing with this slide is that most people, their cycles are about 30 days. So I don't know why these people waited until she had missed her period by 3 weeks before she finally took a positive pregnancy test. I don't know. Most people trying to achieve are taking it every day when they expect it. This is achieving pregnancy in a long cycle. So another great example of why we say don't just look at that day 18. This particular person didn't ovulate until day 24. Okay, so that was almost a full week after when the normal ovulation should happen. They utilized a day that was actually 3 days after she had ovulated. That's what's marked by that, indicated by that little 3 there. And they actually achieved pregnancy then. So showing that even if it's not on the day of ovulation, pregnancy can still occur. This is, I love this slide because this is infertility-focused intercourse. This is pregnancies that were achieved in what we call severe oligospermia. Oligospermia just means very low sperm counts, okay? So these are all, this is actually 3 separate couples, and they utilized NAPRO technology and charting and really fertility-focused intercourse to say, okay, we know that our sperm counts are really stinky and low and like so bad that they've told us we'll never get pregnant. But what they did is they focused specifically on the time of ovulation and were able to achieve pregnancies. Some of these have been as low as 50,000 sperm count, okay, which sounds really high, but in sperm world it should be like millions, okay? What I tell people is that it only takes one, okay, as long as it's the right one sperm to happen. And focusing on that time really kind of gives couples the power to go, okay, we know when we are most fertile as a couple, so we're going to utilize that to our advantage. I'm going to shift gears just a little bit. I'm not going to go real in-depth about NAPRO technology. Dr. Pranger is going to touch a little bit more on that in his talk. But this is going to be a little bit about how I take that charting and then kind of utilize it to help with some different medical things that come up. And as I mentioned previously, we use it a lot to help people with evaluation of infertility, polycystic ovary syndrome, PMS, long irregular cycles, and irregular bleeding. Typically for evaluation, what we do is that we like to see at least 2 cycles of charting or 2 months of charting, depending on what's going on. And then what we do is that we target lab work evaluation around the time of that ovulation. And then oftentimes we do an ultrasound to assess anatomy as well. So this is normally what we see in a normal cycle. So this is kind of 2 things superimposed. So along the top, you'll see that charting the observations that the woman is doing as far as the cycle goes. And then along the bottom, what we see is the actual labs, what was done for lab work. So what we see is 2 separate things that happen. And again, you can kind of see where the mucus cycle is occurring. So the black bars that you see along there, that's estradiol or estrogen levels. And normally what happens is when those estrogen levels start to increase, that's when cervical mucus is being produced, okay? So what we normally should see is that those black bars should go up. And then what typically will happen is that ovulation occurs, and then the estrogen levels drop significantly, but then progesterone, which is what you're seeing on the red bars, the progesterone levels should increase, okay? There are very specific studies that have been done for years and years and years, 40 plus years at this point in time, to help determine what should normal be, okay? When we look at standardized medicine, and again, kind of how we were taught in med school was check these levels on day 18 for ovulation, and this is what normal should be. When we look at even the range that my lab gives me for what progesterone levels should be after ovulation, it says that they should be anywhere from 5 to 64. That's not real helpful for me, okay? When I know that it should be specifically this and such this many days after ovulation. It should be this and such a week after ovulation, okay? There are very specific norms for that. This is what happens sometimes in a dry cycle. So again, you can kind of see along the top, the charting showed that the woman was not observing any cervical mucus. And then along the bottom, you can see kind of what's going on with the labs. So when we do labs for these type of cycles, it's able to kind of help us identify where are we having issues. It looks like initially the estrogen levels are trying to build up and create that increase. It never happens, and then progesterone never quite gets up to as high as it should be either. And so just kind of pairing those 2 things together, seeing the actual charting, seeing the lab work, helps give us an idea of what do we need to do to kind of help those cycles improve. NAPRO is really able to help us with challenging charts, and so people come in and this was that first line was one of the things that we noticed in the infertility charts, is to say, okay, I've got this woman who has 1 day of mucus in her cycle. What can I do about it? Okay. The second line is an example of somebody who had recurrent miscarriages. Looks like things started off okay, should have been okay, and actually weren't in the end. The second and third lines have some irregular bleeding that's happening, so that's much more than the 5 to 7 days of normal bleeding each cycle that we should see. And so just by being able to look at a snapshot of that chart, oftentimes we as the medical consultants are able to look at it and go, hey, something's not right here, and so then we're able to target what do we need to do to kind of look into things a little further. This is an example of PCOS. I get asked this one a lot. And basically what happens is it looks like a longer cycle is happening. So this particular woman is only having a cycle every 1.5 to 2 months at a time. And it looks like her body is trying to ovulate multiple different times, but what we find is that it's not actually occurring. So that's an irregular long cycle. Some of the different treatments that we do, obviously it's going to depend upon the diagnosis. Sometimes this does include bioidentical hormones. But the difference with that is that we supplement it, we time it to the cycles, okay? I really stress the importance of the bioidentical hormones, okay? Because we are not using the hormones that are in birth control, okay? I don't prescribe any form of birth control in my office for any reason whatsoever, because the bioidentical hormones are very, very different biochemically as far as how your body reacts to them, okay? May include sometimes different vitamin recommendations. There are different vitamins that will either increase or decrease cervical mucus. There are different vitamins and sometimes different actual prescription medicines that can help to increase different vitamins and hormones. And sometimes it does end up requiring some specialized surgical intervention. Okay, I'm not a surgeon myself. However, if there are people that are requiring additional surgical treatments, we send them to people who specialize in and who are NAPRO trained. The difference between that is that there are lots and lots of fantastic OB/GYN doctors in the area. However, their focus isn't always on preserving fertility in the long run. Oftentimes their focus is on, hey, let's just fix this problem real quick, we'll put a Band-Aid over it, and by the way, go and try and get pregnant right away because this is only gonna work for a month or two, okay? The NAPRO technology surgeons that we send to have been specifically trained through Pope Paul VI Institute at some point in time, and then kind of have spread out all over the country from there. And so their focus is not only on, hey, let's correct the underlying problem, but let's fix everything that's going on at the same time, and also let's make sure that we are preserving future fertility so that this isn't going to be an ongoing issue for these people. So a lot of this is kind of a scientific background and kind of just psychological and a background for you guys today. So you might be sitting here going, well, what in the world can I do about this, okay? The biggest and most important thing that we want people to do today is go and tell other people about today's talks. Hey, I heard this really crazy thing about microchimerism, okay? First of all, you sound really smart, okay? Second of all, it'll get people going, oh, I didn't know that. That's really interesting. And sometimes that's all it takes is triggering somebody else to spark a conversation. Encouraging other people to use natural family planning. Some of you may not be at an age where you're going to be actually using it currently, but feeling open to talk to other people about it, talking to your kids, to your grandkids, to your neighbors, to everybody you know about it. If you are somebody who's a nurse, get involved, teach. You can teach these methods and support other people who do it. Lay people can teach NFP methods, okay? Many of our practitioners have no medical background whatsoever, okay? And they still go on to be amazing teachers of this. Questions, I understand we're gonna try and defer questions on until the end, but I will encourage you, if you have specific questions, kind of keep them in the back of your head, write them down, and then during our panel we can address them. As I mentioned, there's gonna be a lot of questions, probably as far as the NAPRO technology stuff that Dr. Preiner is gonna address in his also, so I'm not gonna dig deep into that. So with that, I thank you guys for your time this morning and for hanging with us. So get things switched over here.